When we're setting up for a surgery, we usually, let's say if you have time, you can set up, the assistants can set up a lot of things the day before the surgery. And then, or for example, if you have a surgery, you clean up the rooms, preset your operating room for the next day. So I call this a phase one, preparation phase one. So it facilitates things. And I'm also going to talk about how you can stagger your staff. Your office requires a lot of surgical assistants. This is the procedure where 50% and even more of your work is dependent on surgical assistants. So not only do they have to set up the room. What? Oh. I didn't do it. Ghost. So the team of surgical assistants has to be managed in ways that is efficient for you to pay them, but also efficient for them to work and not be tired. And so the more you can understand the big picture, the better you can stagger and organize your staff. We use some places would have patient in one room and a separate room for dissecting grafts. We keep everybody in the same room. Our patients are sedated, so we can chat in the morning, and patients are not annoyed by our stories. Or at the same time, some people would say they like the assistants in a different room so they can chat and not disturb the patient. So what I'm trying to say is, if patient is not it's aware, you may want to maintain some nice conversation and engage the patient instead of just having a chatter in the background. So think about how your office is set up and whether you want to keep everybody in the same room or separate rooms. I like everybody in the same room because it becomes more personal. If the tissue is taken in a different room, it becomes like it doesn't seem like connected with the patient. It's your preference depending on your office and how you can set up everything. During this phase, so what we do is all our instruments are packaged in pouches, so the day before the pouches are laid out. The morning of surgery, I am the first one coming in. I open all the pouches and start presetting, right? So kind of for the surgery. And then, so that means I would open everything, slightly set up, and then as one assistant comes in and next one, they start setting up their station. Everybody will set up the station a little bit a different way. One likes it one type of microscope, the other type of microscope. What I'm trying to say is everybody will set up a little bit maybe differently. That's kind of staggered and done as we progress. And then after this, for example, I open the pouches, the nurse prepares medication, and then the patient shows up. So I am now moving to prepping the patient. So we prepare the patient, change into a gown, and then a nurse will draw blood. We shave the donor area, prep the donor area. Nurse will draw blood. We prepare the PRP because it takes 20 minutes for PRP to spin. And then a nurse moves to administering IV sedation. Dr. Lamb is already in. He draws the hairline, outlines where the patient needs to be shaved. I bandage the patient. We usually put a bandage around the area. So if this is the back of the head, we lift the hair, tape the hair up. This is the area being shaved, and then I place the bandage underneath so that the area where I'm working is clean and everything that is seeping or it's caught by the bandage. So that means that we have fewer assistants needing to assist Dr. Lamb, so kind of making things more efficient. So Dr. Lamb administers, once the IV is in, Dr. Lamb administers anesthesia. We have one assistant assisting physician. We use the distractor. Maybe you already heard about this, but it's easier, it's less stinging on a patient. So the one assistant is with the physician, and the rest of the assistants are now coming in and finishing setup, which means the ice is brought in, the fluids are brought in, and PRP starting to be mixed, depending if it's finished. So those final setup are done. There is this time while Dr. Lamb is doing the anesthesia. Then he harvests the strip. And the moment the piece comes out, what we do, we measure 2 centimeters of the piece. So we know the full length. He decided how much. Let's say he needs 20 centimeters. So we take 2 centimeters of the average density. The density between the sides and the back can vary. So we evaluate that before we harvest. So we say from this area, which kind of has a good sample of both densities, we take 2 centimeters, and then those 2 centimeters are going to be dissected into grafts. Once we have the number out of 2 centimeters, it will give me, for example, 81 hairs, 100 2 hairs, and 52 3 hairs. So that's our sample out of 2 centimeters. So now I know that total was 20 centimeters, and out of total density, total strip, we have 10 times what was in a 2 centimeters. And those are the projected numbers. Then we give those numbers to Dr. Lamb, and we continue dissecting. I sliver, and I have 4 or 5 assistants dissecting. Every office is a little bit different, but in our office is I sliver and hand the slivers. So I have several little dishes, and I hand those dishes as I sliver, and then they dissect them. As we are all working, we're evaluating whether the density is what we anticipated. Sometimes it can be more, sometimes it could be less. We have to provide that feedback and constantly adjust the numbers. So if we see that something as we yield is a little bit bigger or more density we're getting, then what we do is we either take another 1 centimeter measured and kind of count and see how we can adjust the density. Before the Dr. Lamb finishes making sites, we want to make sure that the numbers are matching, right? So it's a constant feedback. The more you engage your assistants in a process, the more they give you feedback. And this is why I like to be in the same room. But however you organize, it doesn't mean the offices where they're dissecting grafts in a separate room is not functioning, as long as you keep that communication going. So as we are dissecting, so you're going to notice here, I'm going to show you, I don't know if you can see. So this is called the Mantis microscope, and I will be covering that. And this is Meiji microscope. So we have different types of microscopes, and I'll explain in the office setup why and how I like those. But just kind of pay attention. So like, see, we have 4 people on a 1 cutting station, and then we have another station with 2. Then it's lunchtime. So he finished, I'm sorry, I skipped the site creation. Sorry for that. So he is harvesting, create recipient sites. During that time, we're dissecting. We usually time things. If we're doing a mega session, the way it goes, we start at 6:45 in the morning is the time when the patient arrives. 7:15, Dr. Lamb makes hairline. We prep the patient. 7:30, we start administering anesthesia. Then it goes harvesting, suturing by 9:15, 9:30, depending how long what's going on. The sutures are finished, and then he continues with the recipient site creation. Usually what happens is by 11:30, if we have a mega session of 3,000 grafts, I am done slivering, and Dr. Lamb is done making sites. So we are going to take 3 of us and start placing, and then the rest of the team is going to continue dissecting until we're done dissecting. If it's an easy dissecting, we may be done by noon. We all take lunch, patient gets lunch, and then after lunch we start or continue placing, depending on timing. That's how things kind of flow. And then it takes several hours for us to place. We're always 3 people placing, and then sometimes you take breaks, rotate. Some offices will have several people placing, which means in our office we have 3 placers. Some others can step in, but we are main 3 placers. So once Dr. Lamb is finished making sites, in the afternoon he has other patients to see. He has the other 2 assistants when they're finishing making grafts. They step in and assist with other procedures. So our team from 6 assistants goes down to 3 assistants in the afternoon. Other offices will send assistants home once they're done. If the assistants are around, they can be cleaning the instruments while we are finishing, or they can clean instruments at the end. When the patient is done, we usually do not bandage the patient. unless it was a FUE procedure. If it's a hair transplant done by strip, we just comb hair, clean hair, and the patient leaves with no bandage. If we did the FUE, we put a temporary bandage about an hour or 2 hours until they get home and they remove the bandage. And in the end, there's a cleaning and sterilization that, depending how your office works, and if you clean everything and then we set up for the next day, if we have a surgery in the next day. Any questions? Yes?
Do they get a goodie bag when they leave?
Yes. So that should be kind of, I don't know if they're covering in a post-op, but what happened in our office, we give them a goodie bag. We have ATP sprays. We give them ATP sprays and they're in the little bottles they can travel with, so I don't have to change the size of the bottle. Some patients are out of town, so that means they can keep the little bottle in there. So we give them 3 little bottles, a little packet of gauze in case there's oozing or anything they need to dab. We give them Regenesin gel, which they are going to apply on a suture line to improve healing. They get post-operative, hard copy post-operative instructions. If they had an eyebrow case, they get a little scissors. I found online a little scissor. They have a little comb, so especially designed for eyebrows, so we give them that. And we also give them survey, so they have to get the survey at the end of the case.